just about at the hour, and we've got a great turnout so far. I'm seeing, I think, at least 23 participants in the call, so thanks for everyone's time today. I think this is going to be a really great presentation. The impetus for this presentation came from the chronic disease work group, who requested some education on the chronic care model, which is the single evidence-based model identified in the project Toolkit from the Healthcare Authority for ACHs to use in their chronic disease project area. So we wanted to get an example of how that model is being implemented in the field, and we had a wonderful volunteer from Providence, Jan Sherman, and her team in care management to explain how they've been using and implementing the chronic care model. So this is Ross, by the way, for those who joined just now. I'm one of the project managers with the North Sound ACH. I'll be running the webinar behind the scenes today. I'll be managing participants, reviewing the questions, and then I'll turn it over now to Heather, who's our project manager on the chronic disease project area, to get us started into the webinar, and then she'll be passing it over to Jan and her team.
Great, thanks everybody. Hi, this is Heather McGinnis, the other project manager with the North Sound ACH. We're really glad that you could join us today to talk about the chronic care model and how it plays out in practices in our region. So as Ross mentioned, he'll be kind of driving behind the scenes. If you do have questions as we proceed with the webinar, please feel free to type them into the chats box. You should see, if you hover down on the bottom of your screen, there's a chat button. If you type in there, you can type as you go, just questions about whatever the content is. You can feel free to target it toward everyone or towards Tiffany Edlin. That's the account that we're on, and that's us, our Sound ACH staff. And we will have time for Q&A at the end, but feel free to type those in as you go.
All right, well, I will now be passing over the
I'm watching. All right, hi you guys. Click to start the mouse key control. Okay, good. Hi, my name is Jan Sherman. I'm a registered nurse and have worked in ambulatory care as a family nurse practitioner. And then in the last 10 or 15 years, really in care management, care coordination, and administration. So this is a topic that's near and dear to my heart. I'm really delighted to be able to share with you a little bit of what I think is a robust model. And with me today is Jamie. And Jamie is our nurse lead and does a great job. She makes this come alive, I hope, for you. And Dr. Patel had a new patient scheduled and absolutely couldn't join us today. So she's really disappointed, and so are we. But we'll go ahead and get started. Jamie, you want to tell folks a little bit about yourself?
Sure. I'm Jamie. I have been in this role for about almost 2.5 years. I've been a nurse mostly with a background of acute care nursing for a total of about 10 years. And so just segueing into this role in the last couple of years, which has been quite a challenge and a change, a welcome change. So it's been really good learning this workflow.
So let me see if I can get my, so the chronic care model has been around a long time. Ed Wegner, and it sort of came out of group health. And it's really interesting if you think about the history of this model, and that a physician and a group said, if we're gonna really change how, whoa, let's make this go back, thank you. If we're gonna change how people live and their health, it's gotta be more than a doctor's visit. So think about that. So much of, you know, the work back in the 70s and 80s was really around urgent and emergent care. So it was quite futuristic. And it said, you know, people live in communities. There's what happens in the health system. It's way more than what happens with the doctor in, you know, an appointment. And then there has to be this translation into people changing their lifestyles and their behavior. And that requires a different kind of interaction to get a different outcome. So he drew this up, and it's very cool that it was way ahead of his time. And here we are in the 21st century, and we still use this model, and it's incredibly important. Let's see, next. There we go. So I kind of like to bake bread, so I made this into a recipe. So, you know, when the model talks about assuring productive interactions, the real ingredient of that is learning what's the patient's perspective and really what the patient sees as their goals. That's the productive interaction. When we use words like self-management support, what that really means is we focus on what the patient and the family's sense of confidence is around their diabetes, their heart disease, their rheumatoid arthritis. What's the skills does it take to take care of this? What gets in the way? And what could overcome that? So really self-management support is learning to see the eyes, see the patient's experience through their eyes as a second set of eyes. We talk about delivery system design. Those are, you know, those sound like fancy words, but just like Jamie said, it's like we have to change how we move people through clinic, how we think about what happens between clinic visits, and how we actually look at care over time versus appointment to appointment. And that really does change how we set up our whole workflows. Decision support is really about making sure that there's more knowledge, more skills to make sure we do the right care at the right time, and not depending on each individual to always know everything, but is it visible? Is it obvious? Does it help us? We live in communities, and what that really means is finding out what clicks for the patient and what's out there, because no one organization, not the Northwest region of Providence, which is, you know, relatively small if you compare us to, say, Portland or to the Swedish Medical Group, we are never going to have everything a patient needs, nor should we. So our community is our best friend. And then if you don't know who you're seeing and who's getting better, who's not getting better, who's not coming in, it's really hard to help people over time. So our clinical information systems is really about having a way of tracking people over the long haul. Those are the key ingredients in the chronic disease model. Oops. So this is where Jamie and I get to be lots more conversational, but when you start doing this work, you really do need to make sure that you have training involved for all of the key staff, and that includes providers, because this notion of seeing the world through the patient's eyes and helping them manage the care and set up goals, it's just not the way healthcare providers are trained. We're fixers, we're diagnosticians. Lots of times as helpers, we have, you know, we get fuzzy about our roles and we don't know what's our swim lane and what's somebody else's swim lane. And so really getting clear on who does what based on what information, and that becomes a reliable, consistent, standard work, is key to making this model work. We use evidence-based guidelines, And that's very interdisciplinary with primary care, pharmacy, nursing, behavioral health. And that's super important for chronic disease management. We track our patients. And then the key to keeping this sustainable for chronic disease is to weave what we're doing for chronic disease management into the metrics we measure for quality improvement and we report out on. That's super important because otherwise it becomes kind of invisible work. And we commonly, invite people in from all of our community resources to tell us more about what they do and for us to figure out how we can actually help patients broaden their base of support. So those are kind of the things that we knew we had to do when we started this program. Let me see if I can. Okay, so into action at Providence. We started with accountable care contracts. Many of you know that Boeing put out, wanted to do accountable care, and Providence participated, and that leadership engagement got us started down this road, and got us funding to dedicate staff to reach out to chronically ill patients and to figure out what preventive care measures they were missing. But I want this to be a story, and so I actually I'm looking at Jamie here because reading bullets off of a PowerPoint is kind of like being back in school again. So tell the story, Jamie.
Okay, so when I first started doing this work, one of the first things that was part of my training was going to motivational interviewing, and that was really a really great first step, because coming from acute care nursing, you are a lot of times like the providers where you don't have a whole lot of time dedicated to delving into the reasons why people are stuck not managing their chronic issues, what barriers they have. Like Jan said, you're kind of the fixer. Here's the medication, here's the therapy, here's the referral, off you go, see me in 6 weeks. So my job as the care manager is to basically form relationships. And when you form a relationship, a trusting relationship, even though it might take time, you've got the time. And that's something that a lot of patients I find are very interested in is, I'm not your provider, but I'm here to help you, and I'm here and to bridge the gap, to give you the time that you need to talk about these things, and let's figure out what you need, because your doctor may not have more than 20 minutes, but I do. So that's where what matters most to you comes in, because that's pretty much the first time I meet with somebody, I'm asking them, what are the top 3 things that bother you most, or that you find are the most challenging in regards to your health? Even if a patient has diabetes, it may not be that important to them that their A1C is under control, but it may be more important to them that they want to lose weight, or they want to eat better, or they want to be able to afford their medications. So finding out from the very get-go what's important to them can help you prioritize. It can help you, start with that trusting relationship, because you're working for them and you are kind of cheerleading them. And if they get closer to meeting those goals, then they're more likely to change and have some sort of behavior modification and kind of do the things that they need to do that marries what the doctor wants them to do and what they want to do. So yes, maybe they want to lose weight, but then if we get your diabetes under control, you're going to lose weight, but you're also going to have the A1C that's in goal, which makes your provider happy and also your body. So it's marrying the 2 things together. And I think that of most of the patients that I talk to, the biggest things that they have are, my provider doesn't have time to listen to me, which is understandable. I know what I need to do, and then they get stuck. And, or it's financial resources and community resources that they just don't know where to start. So they just don't look. And so I think that has been the biggest impact with this, and it's made the most progress, and then getting them set up with all of the resources that they need so that they can be successful.
Well, and I think other part of this model is taking time to talk through with a team what the barriers are and getting more heads together to figure out and strategize. Talk a little bit about systematic case review and what that's like, because that's a big part of chronic disease management, and it's very different than usual care in healthcare.
So every week we have a case review where the nurses from and the nurses, the social workers, the psychiatrists, and the doctor meet together. They discuss patients. We discuss new patients that we've completed intakes on, what their current chronic issues are, the medications they take. And then the pharmacist has already done a pretty in-depth med review. So they look at the medications the patient is currently on, any concerns or questions that need to be clarified about that. And then, you know, either if it's the intake or the follow-up, if you're presenting a patient, you know, if you yourself find that you're stuck on what to go, which direction to go, you've got all those modalities of different people coming together to make suggestions, and then you can bring those suggestions to your patient and the provider the next time after the end of the meeting or before the next time you meet. So it kind of helps you with your own barriers that you might be having if a patient gets stuck or they're not progressing or there's just something that you don't know. You've got all those different modalities to rely on.
One of the things that's really interesting about chronic disease management is really focusing on treating to target and keeping some momentum going. And usually that starts with a patient kind of being activated and more ready. And the things that we find that activate a patient are a meaningful interaction with a physician where they say, I don't know, I just can't seem to get ahead of it, doc. And the doctor says, well, I've got a nurse that might be able to help you, and puts in a referral for care management. So we made an easy button for our providers. Like if you've got a patient that needs extra help, put in a referral and we'll reach out. Even though we're trying to focus on accountable care contracts, providers just see patients and know what they need. And they are, as they should be, insurance agnostic. And so we make sure that all patients get help. And that's super important. And then for providers, we actually knowing that, you know, it's pretty hard to change provider behavior with an email or a conference. We've set up grand rounds where everybody 4 times a year talk about key clinical topics that are related to chronic disease management or preventive health. So they get the newest evidence. We talk about what that looks like in our medical group, and our folks that work in the electronic medical record share, and here's how you can get this pulled up and in the chart easiest and find these guidelines easiest. So that's when we started moving this into action at Providence. We had to do a bunch of different things. We could have the dedicated staff, we could grow their skills and their knowledge, but we needed to bring medicine along with us, and we needed to have, you know, a way to have regular talk and interaction. So that's been really key for improving our chronic disease management. Anything else that I forgot to say? Whoops, wrong button. On side. So this, I think a picture is worth 1,000 words. The main tool that we've used is what we call workouts. And many people in healthcare have been part of collaboratives with the state, and we use a workout model. And so when we started in 2015, there was just this small little group. There was, you know, some physicians, there were some nurses, there was some folks from the Epic team, there were managers, and we worked a lot on workflows. That's all this work in the back. And we designed the roles, who does what when, how it's charted, when do we use pharmacy, when do we bring people to case review, how do we give feedback to the providers. I'll quit talking, you talk more, Jamie.
Oh, well, so it's a way for us to basically keep things going. It's always in a state of transition and evolution. We've grown a lot, and when we grow, we have to clarify everybody's roles and the goals for the next upcoming year. So every year when we have a birthday, we basically have these workout groups where we troubleshoot issues that we've had that that are current issues or continued issues, new things and goals that the team thinks is important that maybe we can implement into the next this upcoming year. And then we establish who is going to be on those teams to help meet those goals. So it's been really good, and I think that you can see from the pictures, obviously the patient need is there. The clinic doctors have really kind of welcomed the work a lot. When I first started, it was still a little bit difficult to kind of have the buy-in, but now I just don't see that as an issue anymore at all. The work is really valued by not just the patients, but the doctors as well, because the doctors understand that they don't have a little bit extra time to spend, but maybe they don't, but they're still able to support their patients through us. And so you can see from the 2 different years, we've grown significantly and continue to do so. And I think it's just kind of indicative that the need and the community needs the work.
Mm-hmm. And the big changes that happened between 2015, where we just started with, you know, basically a half a dozen nurses, and 2016 as we went up to more like over a dozen people, and we started adding social workers to do behavioral health, and we started our integrated behavioral health. And so we have pulled together our integrated behavioral health and our chronic care management team. So they are a large team working together and using each other's expertise and support, so that when there's a psychosocial issue that's so impairing a person's ability to focus, we work on that. And then when their mental health issues are stabilized, they say, now I think I'm going to have you work with Jamie some more, because it's going to, you're going to feel a whole lot better if you can get ahead of whatever disease is this person's chronic disease. So that's the exciting work of 2017, is that we have really built a broad team approach in our primary care clinics that integrates behavioral health, pharmacy, psychiatrists, nurses, and our medical assistants and our physicians. So, that this is kind of just a picture of that. Basically, funny, I got my stripes from my last one. I don't know.
Jan, I'm gonna just take over for a quick second, if it's all right, and get rid of those. I just want to let everyone know on the line, is that gonna hide it? Okay, this is our first time using Zoom for a webinar, and I just want to, there we go, clear all drawing. There we go. And I'll pass it back to you now. So we are learning. This is an active PDSA cycle, so we appreciate your patience as we're going through it. But so far, so good. We're just learning about the pen, which is new to me. But
That's good.
All you, Jan. Sorry about that.
So basically, what we do then feeds into our quality metrics, and that's visible to our executives. That's visible to our frontline staff. It really says, are we making the difference we hope to make? But now I lost my control. Can you forward to the next slide? Hello?
Yes, Ross is working on it. Sorry about that.
That's okay. You can just, you can forward to the next. I don't care. I can tell you when to change slides. I don't need to control that. So here's an example of our dashboard for our quality metrics. And, you know, literally when we started this work, there were very few greens. And you know, in July, in half of our clinics, they met 8 out of all 8 quality metrics. I didn't update this slide with July's, but this helps us all remember, you know, you do measure what matters, and we want to control people's heart disease, their depression, their blood pressure. We want kids to get their immunizations. We want women to get their pap smears, their mammograms, adults to get their colonoscopies. So it's just an example of, you know, what we share. And I would say people get pretty excited when this report comes out. Huh?
Oh, yeah, yeah.
That's pretty cool. Next slide, please. Yeah, it's good on the green. Here.
Okay.
So there's lots of patients, but this is just a patient story.
Oh, okay.
Okay.
So I remember this patient. It actually wasn't one of my patients, is a colleague on the team, and she had a patient who she was working very, very hard. He had he was on the transplant list to receive a liver transplant, and he, sorry if I stutter a little bit, I'm doing this from memory, but the care manager here found out that the transplant clinic normally has somebody who helps the person go through the checklist of all the requirements needed to get the transplant. And once all of those things are accomplished, then they can move forward with their transplant. Unfortunately, that service was cut, and so it was basically put on the care manager here to help this patient, and he had extreme amount of barriers. He had transportation issues. He, because of his liver, he was always going into encephalopathy and being hospitalized, which then he was in the hospital and he wasn't able to meet his outpatient appointments to get his paracentesis or his MRI or something like that. All of his outpatient follow-up and services was complicated and delayed because he was so frequently in the hospital. And so she spent a very large amount of time collaborating between I think his insurance company and all of the outpatient services that he needed, transportation issues. She had HopeLink involved so that they could help him get to and from his appointments. She worked with his provider so that they could come up with a plan so that if he was in the hospital, he could get services there instead of having that delay. And I think the end result was he got his transplant, and it was
March.
Yeah, so it was pretty amazing. And she spent a lot of work, but he wouldn't be alive if she didn't do that work at all.
Yeah, and the patient's doing fantastic. And we recently started with healthcare authorities health homes program, and we have nurses dedicated to the high utilizing, high expense Medicaid population with United and Molina, and she's following this patient and working really with him on his diabetes at this point. So I think that's our last slide, and it's up to you now, Ross. Thanks, everybody. Are there any questions?
Hi, everyone. Thank you so much, Jan and Jamie. If you have questions, I think to make it easier so that everyone's not talking at the same time, it'd be great if people want to type them into the chat box, and we can answer them at the end of the call if that works. But as Ross transfers over control, I will give everyone a few seconds to type out some questions. And again, thank you so much. That was really wonderful. Thank you for sharing your expertise with us, both of you. All right, so what we wanted to do today is, oh, never mind, we're good. So what we really wanted to do today is talk about how this model plays out, will play out in the transformation demonstration projects that we are working on in ACHs across the state. I'll just talk a little bit about the direction that we have from the HCA that's laid out in their toolkit for what this project area looks like. Many of you are involved in this work group already, which is great, or involved in other work groups or across all the different project areas. But just to provide a little bit of background, the objective of the Chronic Disease Prevention and Control project area is to integrate health system and community approaches to improve chronic disease management and control. And the target population, broadly speaking, is Medicaid beneficiaries, adults and children with or at risk for chronic disease, with a focus on those populations experiencing the greatest burden of chronic diseases in the region. We are working, we have a wonderful data specialist, Nicole Willis, here on staff, who is working with the HCA and other bodies around the state to get some great data on our region so we can make sure that we're honing in on those populations who are experiencing the greatest burden of disease. So one thing that we've been really trying to do for all of our project areas is center on the metrics that we are being asked to move by the healthcare authority. So for this chronic disease project area, there are a number of metrics both in the pay for reporting and pay for performance that we wanted to highlight here for you. If you look at the graph, you can see that there is a lot of overlap at the top with areas like opioids, transitional care, and diversion around a number of partners trained on the selected model or approach. However, there are several metrics that are specific only to the chronic disease work area, such as identifying the number of new or expanded nationally recognized self-management support programs, such as CDSMP or NDPP, which we'll talk a little bit about in a second, identifying the number of home visits for asthma services and hypertension, identifying the percent of documented up-to-date asthma action plans, identify the number of healthcare providers trained in appropriate blood pressure assessment practices, and identify the percent of patients provided with automated blood pressure monitoring equipment. So those are activities that we need to make sure are happening in a project that we move forward. And for our pay for performance metrics, there is a lot of overlap, as you'll see, with the bidirectional behavioral health and physical health integration project area, which we will be talking about with that work group and across all of our project areas as we move forward in the planning process. But just to touch on these pay for performance metrics, you'll see that there are metrics around comprehensive diabetes care for eye exams, child and adolescent access to primary care practitioners, comprehensive diabetes care for hemoglobin A1C testing and medical attention for nephropathy, inpatient hospital utilization, medication management for people with asthma, outpatient ED visits, which is a metric across all of our project areas, and statin therapy for patients with cardiovascular disease. So these are largely clinical metrics, which is why it's important that we make sure we have a strong partnership with our clinical and community partners for this project area. So what does the toolkit tell us to do? The toolkit tells us that we need to use the chronic care model as our evidence-based approach, which is why we're having this wonderful webinar today. So regions are encouraged to focus on more than one chronic condition under the chronic care model approach. You'll remember in the target population, it lists out a whole host of chronic diseases. For our region, our work group is talking about moving forward with asthma, diabetes, and heart disease as the chronic conditions we would like to focus on, based on what we saw on those metrics in the previous slides. Those are really the chronic conditions that we are going to be measured on. And while all of the chronic diseases are of course important, that these are the ones we really want to make sure that we're focusing our effort in for this project. However, we are still in the planning phases, so we will continue to keep you updated as things move forward. Great. And Ross is going to talk to you a little bit about some strategies that we can take on under the chronic care model.
Thanks, Heather. So we've been through this great webinar, seeing a tangible example of how the chronic model is implemented in practice. We've heard about what the toolkit says that we need to be working on around the chronic care model and how we'll need to move forward in this project area. And one thing that we wanted to highlight before we open it up to questions and further discussion, and before we moved into our work group meeting on Thursday, was identifying that really the chronic care model is a very dynamic model. It can be applied in different clinical settings, in different ways. And I think one of our assets in this region is that we have a lot of different implementations of the chronic care model in most of our health systems, clinics, and FQHCs, and a lot of innovation around the use of this model. And what the toolkit encourages us to do around the chronic care model is engage with community resources and additional chronic disease management programs. And it highlights specifically the CDC's community guide, which has a lot of evidence-based strategies for disease prevention, including asthma, cardiovascular disease, diabetes. The Million Hearts campaign focused specifically on cardiovascular disease, has a lot of great evidence-based practice for providers and for patients with hypertension or pre-hypertension or at risk for heart disease around self-management of hypertension or accurate measurement and diagnosis of high blood pressure. The Stanford Chronic Disease Self-Management Program have peer educators in the region. We could look to expanding Stanford-trained peer education systems. The CDC's NDPP National Diabetes Prevention Programs are also called out in the toolkit, as well as community paramedicine models. So we can talk more about this as we move forward within this project area. But at this point, we wanted to move into our questions, which I've been seeing start to come up in the chat box. So if anyone has any further questions, please do post those in. I'll start with one question that we did get in from Ryan to Jan and Jamie about the community resources, and he has a really great question about the community level of the chronic care model and how clinics engage with community resources. He says, it seems necessary to the model to build out community-based supports to improve the stability of patients and coordinate between the medical office and the home situation. I think that's a great description of the chronic care model. Are there any current developments around community-based supports at Providence? Any thoughts on possibilities for developing community-based supports with your model in the future?
I don't think we're muted. I can't read the thing, so it was a pretty long question, Ryan, darn it. But one of the things that we've done in terms of community resources is we right away connected with our community Y to find out what our YMCA had for early diabetes and pre-diabetes. We also have met with and connected with our senior services, now called OMAGE, and we have allied health care workers. So when our nurses know that a patient needs Meals on Wheels, needs a home assessment for safety, they can ask, her name is Rebecca, to do that. She reaches out and helps the patient get that signed up and figure out who to call and helps with that. So our relationships with communities are, I don't think it's probably, I don't know what exactly you think would be the best model, but it's always really patient driven. And what we tried to do is have a resource outside of the busy clinic provider MA dyad that they could just hit that easy button and say, this person has housing concerns. Can you help them get housing concerns? And so we have, we have a pretty close relationship with Snohomish County Housing, with Homage, with the Y. Those are the ones that kind of are frequent flyers. You want to add to that, Jamie?
Yeah, in fact, I just had a patient today who was just released yesterday from inpatient psych and with no resources. So the provider grabbed me and said, hey, I really need your help. And I met with the patient today while she was here with her appointment, and she needs housing. She's living in her car. She doesn't have any sort of psych support. There's basically no plan for her. And so my first go-to person is Rebecca, and I will contact her and she will look at the patient's insurance coverage and see what's available in the area for her. And then I just kind of have my go-to resources, like, you know, does she need help with applications and finances? And does she need help with getting set up with a counselor? And who can she see in the area? So I kind of start with step one and I go forward with that. And like Jan said, it is all patient, it's individualized. So it really is based on what the patient feels that they need.
We don't have, you know, people say from organizations coming and into our clinics and seeing patients here, but we do definitely do warm handoffs with our patients to the resources in the community.
Mm-hmm. The other thing that I was going to mention too is for utilization, we have a good relationship and communication with the ED care manager staff, so that we can help if we, you know, see patients who are frequent utilizers, or if they see patients that are frequent utilizers, we work together to come up with care plans to, which is basically, you know, a care plan that the primary care doctor and the care management team come up with for that patient, so that when they present to the ED again, the ED doc, whoever it may be on for that shift, can see, you know, what the primary care doctor and team, who in theory know them better than the ED doc, what they have planned for them to help reduce utilization and get those people back to primary care.
That's using the EDIE system. Yeah.
Great. Looks like we have a few questions for ACH staff and a few more questions for Jen. I want to send those questions to you right now, including what common conditions do you see most focused on in your chronic care model implementation within your clinics?
Diabetes is definitely one of the top ones. And then I would say probably second to that would be depression and anxiety. So it's in the intake process, we already know they're chronic problem list, but sometimes people have depression or anxiety that's not on their problem list, it's not diagnosed, they haven't had a relationship with their primary doctor or felt comfortable talking with them about that. So it might be something that you uncover as a barrier as you form the relationship with the patient. And thankfully, because we've now have a really strong behavioral health team, like we can do that warm handoff to where the patient now trusts us as their care manager, and we can say, well, you know, what do you think about this, and what do you think about counseling, and maybe this might be something that we need to implement, like counseling or a psych consult or something like that to help them further. I would say those are the top three, and then probably
heart failure kind of right behind that.
Yeah.
COPD is a real tough one as well, that I think that we're starting to really look at how can we develop some evidence-based practices to do a better job for COPD, because, you know, we don't see a lot of children in our practice. So I would say, you know, pediatric asthma isn't a big part of our focus at all, but we certainly see the pulmonary disease, and we see the heart failure, diabetes, lots of it, and lots of mental health, depression, and anxiety.
Great. And then we have a question about whether Providence's or other chronic care models include home visiting as one of their services for chronic disease management.
Yeah, the home visit component for care management is reserved for our high cost Medicaid population. And we have a nurse and a social work team that will go see patients at the hospital, see patients in their home, meet with patients at their clinic appointments, be it primary care or specialty. And it's through, you know, the healthcare authorities, health homes. We are a what's called the CCO, a coordinating care organization for two lead entities. And those folks can go wherever patients need to go. I've always said that the nurse care managers can make home visits when they feel like a patient has stalled out and there's an assessment that would only be appreciated sort of seeing where a person is living and what's going on in their own environment. It's done pretty selectively. We're not trying to provide home health. If people need home health, we use home health services.
Great. And we have another question on the clinical side around what's the proportion of patients that have co-occurring disorders?
Co-occurring disorders, more than one chronic disease.
Oh,
that's good. Segue into
all of
criteria.
So the criteria that we have is utilization criteria. They have to have ED or admission criteria within the last 6 months, 3 months, 6 months. They have to have PHQ, which is the depression scale over 10 or over, a anxiety scale of 7 or over, and they have to have at least 2 chronic diseases that are uncontrolled. So whether that be diabetes and heart failure or diabetes and anxiety can co-occur together as well.
So almost everybody that we use care management services are kind of like what we would call the top 5% of patients that are struggling with tough diseases and usually tough life situations.
Great. And then we have some questions that the staff can answer around the toolkit, as well as some just logistics. So around the question of, are we required to use one of these strategies or a specific chronic care model? I think we are required to write in the project plan template how we'll be implementing the chronic care model or elaborating on the chronic care model across the region. Again, our project plans don't have to specifically only include the evidence-based models that are highlighted, but we do need to include them in our planning. And then we also need to make sure that we're going to be hitting on at least the 3 chronic diseases that are called out in the toolkit metrics, which are asthma, diabetes, and heart disease, although we can also look at including other significant disorders around those. Other questions include age ranges for the metrics. We'll share an appendix, the toolkit appendix, which includes the specific descriptions of each of the measures, which include age ranges. Largely, they are between the ages of 18 and 64, although there are pediatric measures that go younger and others that sort of highlight in on a specific age range. And then there's a question of if we're going to share the slides after this meeting, and we will. We're recording it currently, and we'll share the recording, the slides, as well as some of additional resources around the chronic care model that Jen passed along to us. The citation written by some researchers at the formerly Group Health Research Institute, now the Kaiser Permanente Health Research Institute. And any other questions I'm not seeing come in?
If anyone else is formulating questions, go for it. I just wanted to make a little note. There is a typo on the screen in front of you. My email is just heather@northsoundach.org, so sorry about that. But hopefully you should all have my contact info, since that's probably how you found out about this today. So my apologies on that. But yes, our emails are just first name @northsoundach.org. So feel free to reach out to North Sound ACH staff if you have any other questions about what we've talked about today, and especially about the toolkit and the Medicaid transformation demonstration project. I do see a question here about when is the meeting on Thursday. Thank you for that. What we were going to say is that we really hope if anyone is interested in getting more involved in this project area and chronic disease work specifically around the Medicaid transformation demonstration project, we'd love to have you come on board. If you contact me, Heather, I can make sure to get you on the email list and we will keep you involved. We do have a work group meeting coming up on Thursday, and that is from 1 p.m. to 3 p.m. in Mount Vernon at the BHO. in the walk-room room. And so if anyone is interested in coming, please let me know. I can forward you the invitation so that you can participate. And there is a call-in option as well for folks that may not be able to make it in person. But all of our projects will be stronger for the different perspectives and experiences that we can bring to the table. So we appreciate your participation and interest in this work.
All right, thanks Heather, thanks Jamie, thanks Jan for presenting and sharing your deep experience and knowledge around using the chronic care model in the field. I think it's been a really useful educational experience for all of us. And we're looking forward to the conversation on Thursday. Again, any follow-up questions, feel free to email Heather or I, and we'll follow up after this meeting with additional materials.
And yes, just a quick note, the meeting location did change for Thursday. It was originally going to be at Skagit Regional in Mount Vernon. However, we realized we had more interest than we thought, and so we moved it to a larger space at the BHO on Thursday. So we're grateful for staff at the BHO for accommodating us. So we will send out that calendar invite to everybody.
BHO, right? The North Sound BHO?
Yes, correct. That's right, in Mount Vernon.
Thanks.
Okay, thank you everyone. We're going to give you the last 10 minutes of the hour back. I know everyone has a lunch hour to attend to, so thanks for your time, thanks for joining us, and we're hoping to have more of these webinars in the future, so keep an eye out for those if you're interested. Thanks and have a great day.
Thanks everyone.